I'm going to ask everybody your evaluation forms. You know, it's really important when we have conferences like this, staff get feedback. So please fill out those evaluations, and before you leave the check-in desk, make sure you turn them in. If we decide to have future presentations, it's always helpful to get feedback on what was good or what wasn't so good. So it's really helpful. We're going to have a panel discussion now with Chris, who's the family liaison, and Stacy and Lindsay, who are both case managers. And the intent for this is for people to ask questions kind of about the nuts and bolts of what it's like to work in home care. I'm going to ask you to refrain from questions about, and they're important questions, things on like salary, benefits, vacation schedule, and things. These aren't the right people to answer those questions. The right people to answer those questions are outside with the green shirts. So the HR people can help you with lots of those questions, and they are very important questions. But we really want to discuss some of the nuts and bolts, the rewards, the things that aren't so good, the things that are great, what makes being a home care nurse different from other types of nursing. That's what we really want to address today. So I'm going to start out with the first question, and then we'll open it up to the audience. So I'm going to ask Lindsay, why did you choose home care over a different setting?
Now is it on? Yeah. I chose home care over a different setting just because before becoming a nurse, I worked in assisted living, so I got to know the people that I worked with over a long period of time. And I knew in home care that I would be able to do that too. You get to know your patients and their families and develop some pretty strong relationships. Working with patients over a long period of time too, you can see subtle changes in their medical status and be able to respond to that quickly. So little things don't become emergent issues. The relationships are probably the most rewarding thing, though. A lot of the children that we work with are born with their medical conditions, so they don't know any different, and a lot of times it's the families that are really struggling and really need the support of the nurses, and being able to be that support is really rewarding in home care.
Okay, why don't we open it up to the audience now, and if somebody has a question to ask, and just point at you, and just go ahead. Who wants to be the first to step up to the plate here?
How far does the pediatric home services extend, like the area that you guys cover?
There are different agencies throughout the entire state of Minnesota. For our agency currently, I would say pretty concentrated in the metro area, although we do have a pretty good patient base in southern area, Rochester area, that type of deal. I would say pretty much wherever you can bring a patient home that is medically complex and technology dependent, you can bring nurses there.
Great. Other questions out in the audience?
I'd like to hear maybe some different viewpoints about how do you maintain your professional boundaries with families when, and I've been in home care for many years, where you fall in love with these kids. You do become a part of the family, but being part of the family isn't necessarily good practice, if you know what I'm saying.
Well, I can maybe speak to that first, and these guys can maybe offer their insight onto it. When I go into a home with a patient, I know that I'm, definitely caring for them in a different capacity than I am if I'm going to be working for them as a hospital nurse or a clinic nurse, where my interaction is maybe more limited and you don't get that opportunity to develop a relationship. That being said, when I go into a home, I always remember I'm here to take care of this patient so they can be home and thriving with the family, but I am here as a medical professional, and to get caught up with any potential home dynamics or other things that are going on, it's really none of my business. I mean, I'm definitely there to be caring and warm and empathetic and a support to the family, but I also don't want to cause more stress on a family by getting involved in any family dynamics or
By the way, that's a really excellent question. Because in a hospital setting, you know, you're kind of isolated. You're in there for the 8 hours. The parents are in and out of the room, going down to the cafeteria or whatever. But in a home care setting, you're in there day after day after day doing your shift work. And that's a really tough issue. And it's not just boundary issues for home care nurses. In fact, the respiratory therapists we have to deal with that. The home IV infusion nurses who are doing monthly IV infusions with patients all have to deal with that. And in fact, we have had professionals come in and do seminars at PHS on how to work through those boundary issues.
Could I actually add one additional thing to that?
Please do.
Because I know partly what you asked was how do you do that, maybe practically, and I know that's one thing that as the home care nurse I've always tried to set up front with the family, and it can sound a little backwards when I was just up here a little while ago talking about how great it is to really become an integral part of the family, and then you walk in home and you're like, just remember, I'm a professional in your house, and I can't really be friends on Facebook or take your cell phone number, things like that. But I do think families respect that a lot, and if you set that up as the nurse up front, I know from a case management side, we've tried to establish kind of that norm when we go into the home for the first time and we're introducing families to what it's like to have nursing in the house. And when you set up a front like that and just kind of say, here's what I can do, I love being part of your family, here's, maybe we should draw a line, because I don't think there's a ton of black and white in that answer. It's really hard in the home setting, especially when your emotional side gets involved and you care so much for these kids, and it can be really gray, and I think every situation is really kind of unique. But I've always wanted to be helpful if you do remember that you are a professional and you're there for medical care. And if that's the first lens that you're seeing it through, it helps a little bit to kind of keep that when you're in a moment where you're like, I don't know what I should do. And if you kind of remember that piece, I think it can be really helpful.
I also think too that just remembering that those boundaries are really important for your, you can get into sticky situations with boundaries that ultimately can affect your license. So I always think it's okay to say to families like, hey, I'm uncomfortable going there, it's against my company's policy. You can always blame it on that kind of a thing, and usually families will back down. And then we always do up front, we go over boundaries with families, and then families are in service with us for 4 years. And those reminders to both the nurses and the families along the way, because it does, after a while you get comfortable, so constant reminders about that stuff is also helpful too.
When we were talking about this, it made me think of a past family I used to work with. I precepted with this patient. It was new kiddo coming home from the hospital. Mom was so welcoming to the nurses in the home. Oh, just grab whatever you want out of the refrigerator. I'm gonna order pizza, it's gonna be great. And I really set those boundaries. I said, I'm sorry, I can't do that. That's so nice of you to offer that, but it's our company policy. And she did that repeatedly, so my nickname was Rules in that home, and she'd kind of joke, oh, Stacy, she's Rules. And she really ended up liking me and respecting me more, I felt, because I did set those boundaries.
Okay, we can take another question.
Do you feel like you had more ethical dilemmas that you had to face being in home health care, having to work with the families, than when you would if you were in a hospital setting?
So the question is, the people who are streaming in aren't picking up all the stuff. The issue is ethical issues in the home.
That's a great question, actually. I don't know if the percentage-wise of what you'd run into, at least from my experience, I haven't run into what I would say is a larger percent in the home that it would have run into in the hospital. I think one of the unique things about kind of medical care, being a healthcare professional, is there's always ethical questions no matter what you're doing or where you're at. And I would say overall you run into more, but I do think they could be different. And I can't even really think of a great example of an ethical situation I guess I've ran into. If you guys could think on it, say it, but I guess in short, I would say no, I don't think percentage-wise you run into more of them.
I don't know if it totally addresses the ethical thing, but I've maybe run into a situation where I have a conflicting opinion about the way a parent chooses to care for a child or a treatment decision they're going to make for a child. And maybe as a medical professional, I feel that they should be going in a different direction. And it can be a decision like, should we trach our child or not? And I could see, maybe with this particular patient I'm just thinking of, it would be completely beneficial to do so, but the family is, no, I absolutely don't want to, and ultimately, we're there to take care of the child, and the parents know their child best, they know what's best for their family situation. So sometimes those situations come up.
In my experience, I think the ethical issues come up more for children who may be in palliative care or in hospice care than in the day-to-day care of a child with a chronic disease or some type of medical dependency. All right, let's take another question from the audience.
You're just wondering from like a hospital's perspective, sometimes you have these patients that come in for scheduled surgeries and such, and they're ready to go like a Friday evening, we'll just say for example, and then we'll call home care and they say they can't go home because nursing staff isn't there, and they won't be available till Monday, knowing that the discharge could be Friday evening. We're just wondering we just would like to understand, how can we make it better, how can we understand the home care processes as to why that wouldn't happen, because in an adult setting they just do them all,
This is actually a great question, and it comes up all the time, and not just in home care, but for doctors trying to get patients discharged too, is if the patient's ready to be discharged Friday night, and they already have a nursing agency taking care of the patient, but they just didn't plan to staff for the weekend, and they're told to wait till Monday, then we can staff the patient. Why is the patient sitting in the hospital? What can be done that's different about that? And I'm going to leave that to somebody over here.
Well, to add to it, sometimes there are situations that there was an unscheduled, so then they would be scheduled, like the nurses we think from the home care perspective would be scheduled to work with them, so we're just wondering why would there be a gap? Just we'd like to.
Especially if it was because it was a scheduled procedure, why would you punish for that?
Right, and or an unscheduled.
Schedule, so like we're saying, like, oh, if they came in on Tuesday and it's supposed to be, why all of a sudden do you not have
Care for them.
there on the weekend?
So what you're saying is even for planned discharges, it's the weekend, you're told there's no staffing.
And sometimes during the week, for example, the next morning or something. Probably be going to do without us.
That's one of the reasons Dr. Wheeler and I want to do this study, but go ahead and open it.
Well, a lot of unforeseen things happen when it comes to staffing, and staffing in home care is quite different than staffing in the hospital, because you're really depending on that one nurse to be there for their shift, and there's not other people that can cover, although we do have multiple nurses trained in a home, and we always exhaust all options to try to staff. But things that we do to prevent that is, and the doctors talked about it during their presentations, respiratory therapy did as well, we really train families to be that backup caregiver, and that's kind of the most important thing is families really need to have that training, so that way if a nurse is sick and needs to go home in the middle of their shift or can't even come in for the whole shift, that there is somebody to care for that child. So I guess that's one way to prevent that, and we always do when we take a kiddo home 24 hours, with 24 hours of coverage. From day one, we're telling that family, like, hey, there's not always going to be a nurse here 24/7. You need to be ready to care for your child. So we always do what we can to try to staff the case, but ultimately we train families too. And sometimes that happens where there's not somebody to care for the child. So thank you guys for for being the backup.
Because you had a great follow-up question of kind of saying, okay, so let's say they unexpectedly get admitted on a Tuesday, and then you're ready to send them home on Thursday or Friday, and the home care agency says, sorry, you can't send them home, and you're kind of going, well, what would you have done on Thursday or Friday if we hadn't had them admitted? There's a little bit of a logistical piece, and this isn't every scenario, but it could kind of help to understand maybe the complexity of home care. I'm kind of bouncing around actually. So in short to your question, it's because there aren't enough home care nurses, which is why you can't send them out on a Friday, because in general, I think it's always been a pretty common thing where we just say there's a nursing shortage no matter where. Hospitals, home care, you can't hire enough of them, and schools can't put out enough because of just capacity in programs. That was something that I heard frequently when I was in nursing school, so I think you're starting off a little bit behind and just there aren't enough home care nurses. I know at PHS we can't hire quality nurses fast enough to do everything we wish we could do. So that's part of what contributes to what you had asked, but I know for what you had asked, the logistical piece behind it, is, like Lindsay had said, we usually train depending on how many nurses are needed for, or depending on how many hours of care that patient gets. So we'll train maybe a 24-hour care kiddo. We have 8 to 12 nurses for that home. If they're maybe 12 hours a day, we could have 5 or 6 or so. But part of, let's say you had scheduling for the entire week, then they go in on a Tuesday. And usually if it's just for a few days, we anticipate we wouldn't start rescheduling those nurses to other places. But the scheduling piece is all kind of behind the scenes. It's different from medical. And I would say we have in the past, or even have now, more schedulers at PHS than we would case managers, because it's so complex I wouldn't want to do it, to be honest. And because they can keep in their mind, well, if this person's not working here, maybe I can put them here to fill this shift, and I can move this one here to cover that shift, and I can move all this person over here, and I think our record is 8 bumps to get a shift filled in a different home where you can, it's this really incredible puzzle. But if you view nurses from like a resource standpoint of, if we have got a quality nurse who we've hired and we've got them trained and they're working in a home, you've got a patient now, this is the 3rd time they've gone in for the month because they're chronically having pneumonias or something like that. All of a sudden that nurse who is, depending on a 40-hour week paycheck, and they've only been working 15 to 20 hours for the last month or so, there's a high likelihood that they might go somewhere else, because in the hospital you're more guaranteed your hours. You're going to show up to work whether or not they got patients for you, and they'll shift you to different floors. And really, I'm really bouncing questions now, because you could go from an ethical piece on, because that's a difficult thing too about, really managing the resources to get the best staffing for the most kids. And would you like to make a comment?
Well, I would just, this is such a convoluted piece, which is why we have so many schedulers, but just general rule of thumb. If there's an unexpected hospitalization, we don't know when they're going home, but the doc says, I think they'll be in 2 or 3 days. What we will typically do is we'll pay standby pay for a day, 2 days, 3 days. We get to the point though where standby pay isn't full pay, and you don't know for sure when the kid's going home. And you've got other homes that could use this nurse in their home. It's so different because you're not all in one building, so it's so much harder. It isn't like you have everyone coming to the same building. So we talk to them and say, what's your best guess? Well, we don't know. And then what we do is we say, well, you know what? We're going to reassign the nurse. Now, our policy is, and I can't talk for any other agency, we let them know right up front. Okay, based on what you're telling me, we're going to reassign those nurses to other homes, and then we need X amount of notice before a discharge happens. So if all of a sudden they go in on a Tuesday, someone used that example and kept saying, nope, can't go home, can't go home, and then Thursday said, we don't know when they're going home, then I might say, okay, then we're gonna reassign those nurses for the next X amount of days, and we'll let you know when. And how many days really depends on how the kid's doing and what is the likelihood. Like, we have a kid who just had some cardiac surgery and she isn't even close. So we've already told the hospital, you know what, we're reassigning those nurses for 2 weeks out. So, if she should all of a sudden miraculously be ready to go in 10 days, we might not have the package together. It is harder. That's one of the challenges. The scheduling job in home care, I think those of us who have been involved in home care a long time would agree, probably the hardest job out there. You have nurses who want to work because, they like using their skills. You got homes who need nursing, and you're just not all under the same roof. So there's just this constant moving the pieces around to take care of all the families the best we can. But short notice, we try really hard. It is amazing to me. Sometimes you will see our schedulers making 12, 15, even 20 different calls trying to, okay, Jane, maybe if you covered this shift at Joe's house, then Ed can go to Ned's house, and then Sally can go to, we try, and we spend a lot of time trying, but sometimes you can't short notice. And it's just the way it is. That's hard piece to home care that I wish was different, but we work really hard to make sure the nurses get the hours they want, because I understand needing a paycheck a certain size, so we work hard to make sure the nurses get their hours so that they don't feel like, I can't do home care because there's no consistency in the hours. And if once in a while a child's in the hospital an extra day or two because we reassigned them, I know that's very unfortunate too, but it might happen. So
I just wanted to add on to that. One of the, it kind of ties into the boundary questions earlier, one of the ways I think it helps to keep So at least in our agency, nurses are generally assigned to 3 to 4 families, depending on how many hours they work. That ties into the scheduling complexity, but it also means they have more flexibility. They can go to other homes if someone is in the hospital for a period of time. And I think it does help keep boundaries intact.
Yeah, I have a
Yeah, go ahead.
different discharge question. So again, so as a home care nurse, what kind of things would be helpful to you from a hospital nurse who is either discharging or getting ready to discharge a patient that you take care of? Like what kind of things would help better either facilitate that discharge or have a smoother transition to home rather than, okay, well they faxed us all this information, now I have to read it all.
So the question is, what's the best way a hospital nurse can communicate discharge plans, discharge issues to a home care nurse? Who wants to tackle that?
I can start, and I'm sure these guys will have something to add to that. I would say with my experience in working with different nurses at a variety of hospitals with discharges, I would say I know I'm going to get the discharge orders from you. I think even just giving a summary of this is why they were hospitalized, these are the changes to the plan of care, these are the changes to the treatments, these are the anticipated changes to the medication, so then when we get those orders, we know to look for that, and then we also know right away, okay, if this isn't what we were expecting, we're gonna get that squared away right away. So that part's really helpful. And I think too, even any best guesses you have in terms of just your like the patient status, if we're calling to get status updates, how is the patient doing? Do you think they're going to discharge home today, tomorrow? Even if you don't know 100%, like even just a rough estimate or guess of their status is really helpful for planning purposes, I think really for any home care. Okay.
Very good. Other questions we can address?
I'm curious from a home health provider, how do you address, or how do you logistically handle being fired from the family you care for?
Here's a good question for you. So if you're the home care nurse and the family fires you, how do you deal with that?
So, again, I'm in the ICU side of things, and lo and behold, we have a chronic health patient come in. Why are you here?
It happens.
Mom, dad, whatever, doesn't like what's going on, they want, whatever outcomes there are. Unfortunately, with home health, now you lost your resources. Now you're in the ICU until an agency can hire you.
Lindsay, it's yours.
So are you talking the entire agency kind of being
Well,
removed
I
from
guess-
that child's care?
Well, I've seen a nurse for the whole agency.
Yeah. Yeah, and
I'm
I
just
guess
curious how it's handled.
when you're working as a home care nurse, you are a nurse in a person's home, and obviously, home for anyone who doesn't have home care nursing, you go home, you relax, you put your feet up, eat a bowl of ice cream. You know, you can be wearing your pajamas all day if you want to. Somebody with home care nursing might not be able to do that. They need to feel comfortable in their home, and there's a lot of different personalities out there. Some personalities just don't match up, so a family might ask a nurse to leave. We always try to handle that as delicately as possible, because there are great nurses out there that family is asked to be removed from their homes, and it's simply just a personality issue. So we do our best always to just match the nurses up in homes where we think it'll be a success story for both the family and the nurse. And then I guess sometimes, you know, our philosophies at PHS don't always match the philosophies of families, and that's just another issue of not being a great fit. And I wish it didn't happen. Sometimes it does, and those families then go on to find other agencies that where the philosophies better match, and you know, hopefully it works out better. And in the meantime, thank you again to the hospital for being able to have a safe care plan in place for those patients.
Is there a personality screening that you do with the family? My wife and I are complete opposites. My
everyone in this room here is different. Like, I mean, I'm sure there are people that I, you know, in general, I just get along or click better with than I do with others. I've had the experience of being asked not to go back to a patient's home before, and it was no reflection of me as a person or bad skills by any means. It was just not a good personality. Like, it was not a click or a fit. And looking back on it, I could see that it felt kind of yucky at the time, but looking back on it, I'm like, okay, well, it just didn't work. I think a lot of, at least from my experience and the role that I've had, is just doing coaching with both nurses and with families to explain, you know, we set these, you know, guidelines or boundaries with both families and with nurses, because nurses are guests in a family's home, but on the same end, families need to have boundaries with their nurses too. And part of what I've done in the past is, as well as, yes, this is absolutely your home, we're going to adhere to your guidelines, et cetera. And I always try to work with a family and a nurse to come up with a good solution so that everyone can work together well.
It helps that we make everybody take the Myers Briggs before they can start. No, we do not. I'm kidding. No, because we would never want to intentionally not hire a nurse or not put a nurse in the home just on a hunch, kind of. I know we have some specific homes who don't want male nurses. I know in the past, it hasn't happened in home care, but in the hospital, I was asked not to work with patients just because I was a guy and they didn't want a male nurse. And the hospital could never make the decision to say, you can't go there because you're a male nurse. But the families can, because we're in their home and it's their right to be able to do that. And so, as I think from a case management side, that's something we try our best to do. And we try to be careful with it, again, because we don't want to just arbitrarily say, you go here, you don't go here, because we think you won't be a good fit, but we do the best we can to approach that and just kind of feel like if we have a pool of nurses who are all needing some extra hours, being like, well, I know like this one and this one would probably fit great in this home, and then we'll have them go out there and try for it. And we try the best we can to match that up.
Kind of the flip side of that, as a nurse, how do you deal with you're in somebody's home, but then not liking or agreeing with their way of doing things or not clicking with their personality as a nurse? How would you deal with that?
So, great question. What if the situation's reversed and it's the nurse not liking the family she's assigned to?
We've had that happen too. Sometimes, you know, homes can be really difficult to work in, and we have had nurses request to not work in home anymore for that reason. And I think one of the things that is one of the best qualities about a home care nurse is if you can remember to be a nurse who's visible at all times, but also always invisible to that family. Invisible in the sense that sometimes families just really prefer that. Like if they're going on an outing, you're there and you're helping, you're really taking care of a lot of logistics for making that outing possible, but you're not like a person in scrubs leading the family down the mall, you know, and really making a big scene about it. And lots of times you're not. You're just Illusions per the family's preference. But being able to be visible, be invisible in that scene is, I think, always helpful to nurses or to families. But yeah, but when it happens, I mean, it sometimes happens, and I think, you know, if you're a nurse who is working as hard as you can in that home and you've tried to be really, because certainly as a nurse, you're going to come across situations that are uncomfortable, and it's part of being a professional to just kind of step back and remove yourself and say, you know, this family's under a lot of stress, and it's not a reflection on how I'm caring for their child. It's the situation we're dealing with, and if you can take that step back, it'll help you to know and remember that you don't need to take anything personal like that. But like you said, there's just every family's different, and every family's got a unique personality to it, and every nurse has a unique personality, and sometimes it's hard to just make those click, and sometimes you just kind of got to reshuffle to make a better fit somewhere else.
And we do work on that. Certainly, we're all from the same agency. You know, sometimes it's a parent who, you know, sometimes it's a fabulous nurse, but maybe she's too professional and not homey enough. You know, I mean, it can just be little things, but we have enough cases that, okay, fine, you know, we can try and meet that personality, that this person who has to have them in their home for all these hours is going to be more comfortable. Sometimes the family will say, not my favorite personality, would you see to it they don't work more than 2 shifts a week in my home? Okay, that's easy. Sometimes the nurse said, you know what, that's not the home that I feel it's not working for me. Now granted, like Chris said, first we're going to work with her. What do you mean it's not working for you? But If it's a huge job satisfaction thing, then we have other homes we can put that nurse in also. And we do try and accommodate, because we do know it's different than going into a hospital, you know, working your shift and having the patients turn over typically more frequently than what we have in home care. It was interesting. We had a conversation with the mom recently, because Lindsay up there's a case manager, and part of what she sees as her role is to talk to parents too about how they can make their home a more comfortable environment for the nurse. And so the president of the company happened to be talking with one of our moms and saying, you know, the more comfortable the environment is for the nurse, the less turnover you have. And she goes, oh, I know. Lindsay told me already. I got that down. But part of the case manager role too is to help the families understand that it's a partnership. You try and make your home a place that somebody wants to come and work for 8 hours or 10 hours or 12 hours. The nurse, you maintain your boundaries. Remember, you're the nurse. You're not their best friend. You're not auntie so-and-so. It's a balancing act, but I don't know. I think for a lot of people it's done well and rewarding. So.
Yeah, I think Sandy kind of said what I was going to say, but if you're feeling that way in a home as a nurse, depending on the situation, other nurses that work in that same home might be feeling the same way, and I would definitely give feedback to your case manager, however it's laid out, your supervisor, so that they can talk to family too, because families don't want to be without their nurses, and sometimes if you just talk to them about what's going on, they're willing to change. So.
Okay, can we take some more questions? Somebody had one.
Do you guys require your PICU, like the patients that you, per se, in a PICU, do you have your nurses before they discharge come and like shadow the nurses there to kind of get to know the patient a little bit? And if so, like, what is it like a half a day, or what's the requirement that you like?
So the question at hand here is, if a patient's ready to be discharged from the pediatric intensive care unit, does the home care agency send nurses in to meet the patient before the patient's discharged home?
Typically, what we do, or from my experience, is we'll identify the nurse preceptors that will be bringing the patient home from the PICU, and they will go and shadow typically the bedside nurse. Families typically present as well, because we feel it's so important that nurses see how families like to perform cares and have things done, because definitely their preferences may be different than what is standard in the hospital setting. Time spent could be a couple hours, depending on the types of things that are reviewed at the bedside. And from what I have seen with both the family side and then even the nurses that will be going into the home to train the nurses working with the patient, are both feel a lot more comfortable. When the patient comes home, from the family perspective, this is a face that I've seen before. It's not some stranger that's just walking into my home on day one. And then on the nurses end, they too feel more comfortable because they've had exposure to that patient and have met the family before.
Okay, another question, please. It's my turn to ask a question. Oh, there is one. Go, please.
So we're going into these families' homes, and I'm just wondering, as a nurse, what is our role, since we're supposed to be visible and invisible? If the family's involved in illegal activity, but it's not affecting the client, patient, what's our role then?
So the question is, if you're in a home as a home care nurse and you notice some illicit activities taking place on the premises, or I assume immediately outside of the premises, what's your responsibility as the home care nurse to that patient, that family, to society?
In that situation, we typically remind families that we're mandated reporters, and it's not a personal thing that we're looking for something where we want to report them. It's never ever that, but because we are healthcare professionals in the home, we are legally obligated to report certain illegal activities that we see, whether or not it's directly affecting the patient or not. And we've done it in the past, and sometimes, you know, there's difficult scenarios that come after that you have to deal with, but we do it, we have to do it no matter whether or not we want to.
Keep questions going.
you go to people, then your supervisor and say, I see this going on, or how would you go about saying something?
Typically, if a nurse in the home is noticing something like that, it would be reported to a supervisor or the case manager that is caring for that patient, and then they would kind of take it from there and investigate a little bit more, and depending on what was going on, then report if necessary.
I can tell you that it's uncommon, but in the past, we have had issues where the activities jeopardize the care of the patient, and those are reported to Child Protection Services. So if the client is at risk, we have reported patients to CPS.
What, as a nurse, like, is there like a good communication with CPS from the nurses? Like, say CPS is out at the home, what's our role in communicating with them?
Well, I'll let one of the nurses deal with that question.
I would say,
What was the question?
The question was, if you're a home care nurse and Child Protection Services is visiting the client, what's the role of the home care nurse in interacting with CPS? Is that right?
I would just say that the best thing to do is probably just answer their questions and follow their lead. In that situation, they're the professional in handling that scenario, and they would always ask the questions for the information that they need. And usually by that point, if CPS is going to be in the home, an initial referral has already been made. Usually that's made from a case manager or a supervisor, but certainly with the nurse's input, because they're the one in the home that witnessed whatever had happened. So if there were follow-up questions, I would say just answer their questions and follow their lead on it, but there's nothing specific you would need to know what to do with it that they couldn't tell you how to do it.
The issues that we've had, and again, I really want to emphasize, these are really uncommon, but let me give you a scenario. A young infant who's, let's just say, has a critical airway. If that child's tracheostomy tube occludes, that child can't alert somebody. That's why they need somebody to be vigilant and next to them 24 hours a day. The smaller the tube, the greater the likelihood they can occlude. We have had circumstances where somebody shows up and the child's in another room, there's no monitoring system, there's nobody attending the child, and clearly has been in the other room for an extended period of time without anybody observing. That child is at risk for sudden death from an acute airway obstruction, and that is something that would be reported. Okay, do we have another question?
Well, I just wanted to add one thing, that as a nurse myself, while telling my supervisor may be a part of the equation, it may not fully absolve myself of further responsibility as a nurse to act independently regardless of what my supervisor does or does not do with that information. I still may have to pursue, whether it's calling CPS or law enforcement agencies or whatever, to protect my own license. So it's not just the agency that's at stake or the supervising nurse or the physician, but you have your own tail end or license to look after as well. And legally, that has become an issue recently in some cases where it was like, well, I told my supervisor, and they said, that's not enough. You still should have known better. You need to be calling other agencies and a little more vigilant to protect your client or your patient.
And that is absolutely true, and if the person, what we do is actually the person who witnessed it is the one making a report, but they have the assistance, they get other people involved. We have a social worker involved who, her help, a manager's help, but absolutely, if you were a nurse in the home and you felt that this was a child protection issue and you reported to your supervisor, said, nah, we're not gonna report it, but you feel it's a child protection issue, you still, just what he's saying, need to report it. We don't run into that because if our nurse tells us, no, this is a child protection issue and that's how they feel, it does get reported. We'll discuss it with them and you know, if sometimes it's more of a cultural thing than a child protection thing, we'll talk about it. But definitely, if you're in that situation where you really feel you have a child protection issue and you're whoever you report to is telling you not to report it, you do have that mandate to do it. So I totally agree with what you're saying there. Typically, our policy is just to have that support. Child protection will frequently speak to whomever it is who was actually in the home and witnessed it. So that isn't unusual. We ask them if it's okay if the supervisor is in there at the same time, just because as a nurse in the home, if you saw that, you're probably really nervous and you like having somebody else there. But they are rare, thank goodness, but it happens. And we, you know, at least our agents, and I'm guessing most of them who've been doing home care for long, have had opportunities where they've had to report.
And I just want to add a note, each county is different, so they may handle it differently, but that doesn't remove your obligation to report. So, you know, if you are not familiar with some of the things, it's medical neglect, as well as some of the typical things that you might consider reportable.
Okay, who else has a question we can answer?
This is a question Dr. Wheeler brought up this morning about readmission rates to hospital, and that the low readmission rates are really due to the quality of home care nursing. So my question for you is, how do you measure those quality outcomes? Or how are those quality outcomes measured? Or what are you looking at, or what is that actually related to?
Well, I'll try and answer that on behalf of Dr. Wheeler. I was not part of that investigative work that Dr. Wheeler did, but we have had discussions about that. So it's somewhat complicated because all of those things are done retrospectively by chart review. So I can tell you, having done that, reviewing charts, you know, people just keep, and those of you who have worked in hospitals know that the doctors just kind of copy the note from the previous day, they repaste it, and they just change a couple of things, right? So day to day to day, you don't see, does anybody disagree with me? So day to day, you don't always see too many different changes, so sometimes it's difficult to sort out, and information is left out, like nobody puts in there, I don't know, nobody puts in their note, I don't know why this kid was admitted, right? So this is how Dr. Wheeler and I have talked about it and looked at it in the past, and I think the question is that if the, first of all, if the admission was 3 days or less, I think you could ask yourself the question, is there anything that was done for this kid in the hospitalization that we couldn't have escalated the therapy at home? So, you know, that's one of the important questions. And the second thing is, Dr. Wheeler addressed that briefly in his talk when he mentioned they looked at the interventions the child received while he was in the hospital. So let me give you a for instance. The kid has asthma and he gets admitted, and they don't put an IV in him. They give him oral steroids, and they give him frequent albuterol and ipratropium nebs, and the kid gets better after 2 days and goes home. Couldn't he been on oral steroids at home? Couldn't he gotten frequent nebs at home? So he went in the hospital for $5,000 a day when he didn't get an IV, he didn't get oxygen therapy, or whatever the therapy that was specific to the hospital. So I think when people are looking at these readmission rates, those are the kinds of things that they're looking at. So the long admissions kid came in, he was septic, he had pneumonia, he got admitted to the PICU, he was on high settings on a ventilator and other interventions and pressor agents. Well, you're not going to be doing that at home. But short hospitalizations with minimal interventions that you could have done at home. So the kids, for instance, the kids who have trachs, ventilators, and ED, they all have oxygen at home for their ventilators. So when they get sick, do they need a little bit more oxygen? Quite often. Can you do that at home? Sure, you can increase the flow rate of oxygen there. You can put them on antibiotics at home, and you can put them on steroids at home, and you can manage them as an outpatient. In fact, the tracheobronchitis study that we briefly mentioned, Dr. Wheeler and I looked at readmissions, and for respiratory problems in those kids, not other types of things. We didn't worry about diarrhea or planned surgical admissions. We just looked at respiratory admissions. 50% of them, half of them, were 3 days or less. And these are all kids with trachs at home who have oxygen, nebulizer machines, and everything else, where I think you could have just turned up their oxygen at home, put them on steroids at home, put them on antibiotics at home, and they probably could have avoided a 3-day hospitalization. But I can tell you, in reviewing the medical literature, it's really hard to tease some of that out. And there was just a paper that was just published on it, where they looked at a bunch of articles on readmissions. And that's one of the things that came out of the article is, you know what, it's really hard to sort out whether this was definitely a kid that needed to be admitted or one of those ones where the kid didn't need to be admitted. So it's often hard to sort out.
I actually just came in town last night from a conference where we were talking about data measures, quality data measures. And a way that kind of helped me understand that was they were broken into 3 different categories, structural categories, and that's really characteristics of the setting in which the care takes place. Process quality measures, which has to do with the percent of time the patient received the required treatment. And then outcome measures, which is really the results of the care that was provided and the interventions. So some really great stuff going on in the Medicare marketplace with 5-star ratings, and they're really looking at driving that into the home health setting. So.
Okay, do we have any another question we can take in the audience? Well, maybe I'll answer one. Oh. Yes.
What kind of advancement opportunities are available for home care nurses? So once you're a home care nurse, what else can you do with it?
So the question is, once you're a home care nurse, how can you advance yourself in the profession or whatever?
Whatever. There are a lot of opportunities for advancement. I am living proof of that. I started out as a home care nurse, first as an LPN, went back to school, got my RN, came back as a home care nurse again, quickly was promoted into a preceptor role where I trained nurses in a home setting, did that for about a year and a half, and was promoted into a case management type role, and then most recently was then promoted into a supervisory position as well, where I supervise nurses. There are tons of opportunities for advancement in home care, and I'm sure that Lindsay and Chris could speak to some of that as well. But definitely, I think really like the sky is the limit with it, whether it's more like a supervisory position that you seek or more like a hands-on like mentor type role, which a preceptor role is.
Okay, we have another question from the audience. All right, now it's my turn to ask one. So, Stacy, I'm going to hit you since you're holding the microphone. Describe for me what a typical day is like for a home care nurse.
It's very hard to come up with what the typical day is because there is no typical patient. That being said, I went to kindergarten for a year with a little boy when I first started out in home care. So I would get to my shift in the morning, I would get a report from the night nurse. I would do my emergency checks really quickly, gather up all my supplies.
Yay!
Yep. I washed my hands too. That's just fun. Gather up my supplies, and we were out the door to the end of the driveway to hop on the bus, and I went to kindergarten all day. And while I was at kindergarten, I attended to all of the child's medical needs, suctioning, feedings. He was not a ventilated child, just a trach child, but he had frequent suctioning needs, respiratory treatments that we were given throughout the day. I took him to gym class, helped him participate in that capacity, did his therapies at school, and also assisted him so he could participate in the school setting, so that he could be there amongst his peers and learn and be a normal kid. I worked night shifts where I've gone in and my patients slept all night, but I'm busy doing maintenance on the equipment and I'm doing assessments frequently throughout the night because they're a trach and vented patient and you can't leave them alone. You need to have your eyes on them at all times. Done treatments, medications, feedings, all of those things. It's really hard to say what a typical day is, or you can be at home all day. You can have your therapies come to you in the home setting and work with the school teachers. Or I've gone to Nickelodeon Universe at the Mall of America before. I've gone to the State Fair. Like, you go anywhere that your patient goes. So it's really hard to say what a typical day is, but those are some of the days that I've had.
What about Disney World?
No, I have not been. Yeah.
Give Chris the mic. What did you say?
Oh, I was just gonna say, we currently have 5 nurses down in Orlando. With 2 different patients that are going to Disney World and having a lot of fun. I actually called one of my moms the other day. When I mean that, I mean my patient's mother. And I ended up calling on my mom. Like I said, you get really close. And I said, we'll call her Jamie. I said, Jamie, how's it going? And she said, I just got off Buzz Lightyear and I kicked the nurse's butt. She thought it was just so much fun, and they were having a great time. But I really got lost in what I was saying. I forgot the original question.
Well, the question I had is, if I was a home care nurse, is there a way I can get assigned to that family?
Well, I mean, a lot of times these happen with Make-A-Wish trips, and from what I understand about Make-A-Wish, I think they're usually one-time things that Make-A-Wish does for you. And so, although we've sent a lot of families through there, it's not usually repeated. But I know when our nurses have had the chance, they've really enjoyed that. And we did one case manager, we did go on a trip like that.
I don't know, Roy, it'd take a lot of training, I think, before you could handle that.
The nursing license in Minnesota is weird. I don't think it's a transfer state. How do you handle that?
So the question is, if you're with a patient outside of the state, how are you covered based upon licensing?
The way we typically handle that is you do need to get a license for the state that you're going to be practicing in. And so for our nurses who fly to Florida, we call the Florida Board of Nursing and figure out what the requirements would be and how we can get temporary license, and just go through that process with them.
And actually, a lot of times they'll have a period of time where you don't need another license. So most states out there, if you're licensed in Minnesota, and not every state, but most of them, if you're licensed in Minnesota, and you're gonna be in a state under 2 weeks, they'll let you work off of that license, appreciating that people go on vacation. So that's more common where. There's some where you'd have to go through a long process to get licensed, and we've actually had a family who was going to go to one of those where we said, there's no way we'd be able to get our nurse's license. It would be an involved process. I think sometimes it helps that some states maybe don't have a blanket with every state they'll do that, but Minnesota in general has a pretty good reputation for our nursing programs. So I can only think of one state right now. I'm sure there's more, and Barb Weisenberg, our director of nursing back at the office, handles this usually, but I can only think of one state right now who wasn't willing to, as long as it was in this period of time, willing to let you work as a nurse in their state, licensed in the state of Minnesota. So it's usually not too hard.
Okay, I think we're going to end it for questions. We're going to give the Facebook contest winners, and then we're going to take a brief break and come back for our last speaker. So the Facebook contest winners are Christina Hesby and Tabitha Erlinson.